So good morning, everyone. I would like to thank you for welcoming me here. I've been too far for Saviol. I've gone too far for Saviol, but I like it. And I would like to thank Alexander and Hatice for their kind invitation. I like to cooperate with this group because it's a group of young people that develop and grow really fast. And that's something that I admire, and thank you for that. It's not only that they contribute in science, is that they improve our everyday life. And that's really important. And I like that development. I like that rapid evolution, and it's really remarkable. And thank you for that. So I come from Greece, really far from here. And I'm here to give you some insights about how to take advantage of that valuable tool that you now have in your hands. So I assume that most of you are surgeons. Is it someone who is not a surgeon, not an ophthalmologist, maybe an optometrist or something else, or no? So probably many of you have already some experience with the LUCIDIS. What makes us happy with LUCIDIS is that it gives us everything. So we like that it behaves like a monofocal lens, just exactly as Alexander said before, but it functions as a multifocal. Actually, I like to call it varifocal. I will explain you why. So what is that we want after all? What do we want for ourselves? Let's say that we are the patient, that we develop presbyopia. What do we want for our friend over there that we will operate on, or for our patient that we will operate on? Well, what I would like for myself is to see far, okay? But I also want to see near, and in between, somewhere intermediate, without glasses. Without glasses does not mean necessarily that it's a luxury to be without glasses, but it may be a necessity. It may be everyday functionality. So it's a need and not a luxury. But also be able to drive at night without halos and rings and glare and all those issues. So actually, I want it all. Can I have it all? Yes, we can. But before showing how to have it all, we need to determine what is far, what was intermediate, what is near. Well, we do know that, we take it for granted, but our patients maybe do not know that. So it happens frequently that I'm talking to a patient over there, and he assumes that a distance of 2 or 3 meters is considered close, whereas that is far. So we need to explain to the patient, and throughout our conversation, determine what is far, intermediate, and near. So let him or her describe what his or her needs are, and also speak the same language. So now I also welcome you in that wonderful world of LUCIDIS, and I will start from the end. What are the take-home messages? So first of all, forget about visual acuity. Well, all lenses work perfectly. They give us 20/20, et cetera, et cetera, et cetera. But now visual acuity has moved to visual quality. Not all 20/20 visions, visual acuities are the same. It may be 20/20, but with poor quality. And cataract or a refractive lens exchange procedure is a quality procedure. So we ask for visual quality and not acuity only. The second thing is to put the term dysfunctional lens syndrome in our vocabulary, to include that. It's not only cataract patients, it's refractive patients. And I will show you a good example of such a patient. So let's use the term dysfunctional lens syndrome because it will help us with a lot of things. So forget about clear lens extraction. It's a wrong term. Go for refractive lens exchange for many reasons that we will discuss. Don't go for a diffractive lens if you have a non-diffractive or refractive lens. And I like this classification, the new classification that was shown by Alexander just a few minutes before. It's something that I was always mentioning and depicting in my presentations, and now it has been officially also published by the ESCRS. It was completely wrong what we were doing so far, but we were unfortunately based on a term that was provided by the American Academy of Ophthalmology regarding EDOF lenses. And that was so confusing and mixed things up instead of clearing things. So the term EDOF was standing for a lens that provides a little bit of additional intermediate vision without explaining the quality of the optics, namely diffractive or non-diffractive, and the performance and functionality, whether it's full range or partial range. So actually, EDOF was by definition a partial range lens that could be also diffractive. Well, this is crap. A real EDOF is a lens that increases the depth of focus and could be full range like LUCIDIS and should be non-diffractive. Not trifocal, not multifocal, not bifocal or whatever. It's a continuous range of focus that can be full range. So the new classification in partial or full range plus the quality of the optics is the correct thing to do. And LUCIDIS stands really top because it provides, as Alexander showed you before, full range with no diffraction. So actually, it's like a monofocal lens functioning like a multifocal lens. That's what we have over there. And some pearls and tips how to make the best out of it. We will go through these. As I said, 20/20 vision does not necessarily mean high quality of vision, but we are seeking also for quality. And the way to measure that, the best way is aberrometry. Because with aberrometry, we have an objective evaluation of the subjective complaints or description of the vision of the patient. So we can understand objectively how the patient sees his complaints, his requests, his description. It's some patients that can really describe it so nicely. Well, I can see like that or like that, and they draw it, they make a drawing. Well, I like that. It's not that they are obsessive compulsive over there, they help me with my job. But I can also understand myself how the patient sees. I can explain possible problems or possible complaints. I know what to expect, and I can describe that in advance to the patient. So it saves my life. That's what ray tracing aberrometry does. And you get some maps like that, wavefront maps. They look like topographic maps. You are probably familiar with that. But please keep in mind that this corresponds only to the pupillary area. That's not the whole cornea. We're interested in the pupillary area. So it's only part of the light, but it's the one that makes the most impact, the highest impact on our vision. And that's the light that goes through the cornea and the pupil. Wavefront is definitely dependent on the pupil diameter. So we take different wavefront maps at different pupil diameters. So it's definitely pupil dependent. It may be light dependent, mesopic conditions, scotopic conditions, etc. We don't need to do all this work in advance because there is a device that can do that for us. But we also need to differentiate between low order and high order aberrations. I will not go into many details and will not confuse you, but let's put it like this. Low order aberrations can be corrected with glasses. It's easy to remember. High order may cause a problem because maybe we don't have an easy way to correct high order aberrations. Let's move to the dominance of the eye. Which eye is dominant or non-dominant? We live in 2025, and we continue to evaluate and determine dominance like what we were doing 1 century ago. It's stupid. There is no dominance. We could use the term objective dominance, which makes sense. So for example, if one eye is amblyopic, yeah, well, it's probably non-dominant. If there is a scar over there, it's non-dominant. If there is a lower visual potential, clearly lower between the one eye and the other, well, the eye with a low visual potential is probably non-dominant. Another way to determine objective dominance is the objective evaluation with ray tracing aberrometry. So once we see a clear difference, huge difference, significant difference between the two eyes, then we assume, we cannot tell, because, you know, it's not the eyes that see, it's the brains that will see. So we assume that the eye with the lower high order aberrations will perform better after the operation. We assume that. That's not necessarily true. But at the end of the day, we do have an objective way of determining which eye is dominant or not. Yet, this will not make a huge difference in our choice, unless there is a big difference between the two eyes. So you don't need to start questioning and asking, well, which eye should I do first? If the difference between the eyes regarding objective functionality is small, then it makes no difference. And I will tell you which eye to do first. So that's a new approach regarding dominance, dominant eye. Let's move to the term dysfunction. It's good to include that in your everyday vocabulary. It will make your life easier. It will justify your decision. You will explain things easier to younger patients that you have just sitting in front of you. It's the lens that makes all the problem. It's the aging lens that will develop presbyopia because it will lose its functionality regarding reading, but then it will lose its functionality further before we reach cataract. So there is a period that may last for 10, 20 years, that may start even early at 30s, in our 30s, and present with dysfunctionality. This dysfunctionality is not cataract, because cataract is theoretically described as the loss of clarity. Well, how can you tell that a lens is not clear? Subjectively, only when you examine that lens at the slit lamp. Or you might use densitometry, or you might use anterior segment OCT and see whether there are some opacifications. But are they always real over there? The only way to objectively evaluate that is with ray tracing aberrometry. And then you might be surprised because you may be having a 40-year-old patient sitting in front of you just complaining about poor vision and some minor change in his refraction, which is not a big deal. And the reason might be that although the cornea is doing well with low, high-order corneal aberrations, the lens is not doing that well. And we have a way to measure that, and we call it dysfunctional lens index. And once the dysfunctional lens index drops from 10 to 7, then, well, we might consider that there may be a problem there. If it drops below 5, then there is definitely a qualitative impact on his vision. So this might be a 35-year-old guy there, or a 40-year-old guy with 20/20 vision, still complaining about some poor quality. And you might think that it might be the tear film, which makes sense, but it's not. Or you might assume that it's the cornea, but you can measure it and you see that corneal aberrations are low. Then what's the problem? It's the lens. But you never thought of that in the very first place. It may be the lens. And that is the dysfunctional lens syndrome. And it evolves over time, and we can follow the patient and explain to him how this this functionality evolves over time and develops. So why perform laser in such a patient when the problem is the lens? Oh, but he's just a 40-year-old. Yes, but the problem is the lens. We don't wait for cataract to develop. It's a lens issue. We explain that to the patient and we know that we are doing good and we are choosing correctly. That's why we call it not a clear lens extraction, because the lens may be considered being clear subjectively by us at the slit lamp, but the lens is not functioning properly. So it's a problematic lens, although the patient is young. That's why it's a refractive lens exchange, which is good to use that term. It's good to use that term. Why? Because we don't use the term clear lens, because the patient will object and say, oh, doctor, why do you take a clear lens out of my eye? Or if something goes wrong, then he will blame you and say, well, my lens was clear. Why did you take it out? So it's not a clear lens. It's a problematic lens. It's a dysfunctional lens. Oh, that's a different story. Again, you cannot tell a 40 or 50-year-old guy there that, oh, you know you have cataract. Well, you know, it's something happening with your lens and it's just coming after presbyopia. Well, it's not cataract, but it's not functioning properly. And this will justify everything. And again, you use the term refractive because this explains also your choice of using an EDOF lens. And implanting an EDOF lens is not a cataract operation. It's a refractive procedure, which is the correct term. And this will also justify you asking for more money for that surgery. So that's the term to use. And now let's see in real life what Alexander described previously. So this is all the pictures that you will see are coming from our patients. And this is what the lens looks like after being implanted. You see the refractive surface of 6 millimeters. Good for distance vision, and the central aspheric surface over there, just that droplet, which we can hardly be seen. It's not that obvious. It took me a lot of effort to take that picture so that it can be visible. Most of the times you can hardly see that. Almost all of our patients that have been operated and implanted with the LUCIDIS, if someone else examines them, the other person cannot tell whether they have been implanted with a multifocal lens. It looks like a monofocal. This can hardly be seen. It took me really a lot of effort to take that picture. So this extra area over there will give you that intermediate and near vision just Alexander showed you. And look how small that area is. And that's why it works even in patients, actually they're not patients, with a small pupil. LUCIDIS works even with a small pupil, which was a major drawback for multifocal diffractive lenses, which is also a big drawback for other EDOF lenses in the market. Good quality EDOF lenses, but LUCIDIS performs better because it performs really well also with a small pupil. And you can see it over there. Stop using the word multifocal. Why that? Because the same patient that is entering your room asking himself for a multifocal lens or multifocal correction, it may be the exact same patient being afraid or scared of multifocal lenses. It's awkward, but this is how it happens. That's real life. So it's the same one asking, oh, I want to see far and intermediate and near. So, oh, well, then you were asking for a multifocal lens. Yes, but you know, a friend of mine was implanted with a multifocal lens, or I was wearing multifocal glasses and I could never spectacles and I could never get used to that. I freak out. So although he or she is asking for multifocal correction, he is scared about multifocal lenses. Stupid, but that's how it is. Then you can use varifocal, which is actually more correct. And why is that? Because we are not talking about multiple focal points. Multifocal means, as a term, that you have multiple focal points, multiple foci. Instead of that, we can use varifocal because we have a varying focal distance. It's exactly what Alexander showed you before. So you skip a term that might scare the patient and take advantage of a new term that shows also evolution. And patients like that. So that's the last model. That's the new model of Porsche that I'm implanting you. And that's how it works. And look at the beam, the pseudo non-diffractive beam that was shown before that can be evaluated also objectively. What you see over there, it's only the pupil. So we are talking about a diameter of 3 millimeters over there, and you can see that central area that gives the additional power of 2.5 diopters, which is more than enough for reading, and intermediate, of course. And you see the pre and the post, and you can measure the difference objectively with ray tracing aberrometry. So this confirms the theory. You've heard about the theory, and now we put it into clinical practice. Diffraction causes dysphotopsia. Diffraction means rings. It may work, but it also causes problems. So diffraction means different focal points, means inevitably rings around the lights. On the contrary, we have lenses like LUCIDIS that work differently, and we can see how differently they work. It's not, actually, we have measured that they do induce a little bit of central spherical aberrations, but in a way that does not decrease contrast sensitivity. And this is an aspheric lens, exactly as Alessandro showed you before. This is negative spherical aberrations, so the peripheral beams go a bit farther, and this is positive spherical aberrations, where the peripheral beams go a bit, focus a bit closer. What that central element does, although theoretically aspheric, because of this bumping, small bumping, it may cause a bit of negative, not positive, negative aberrations, which can be measured. And this gives that depth of focus without increasing without decreasing contrast sensitivity. So this is how it works over there. And we can measure the contrast sensitivity in a more objective manner. That is called MTF, modulation transfer function. It's actually an objective description of contrast sensitivity at different wavelengths, at different contrast. This is measured in cycles per degree. Just to make it more simple, we measure all total aberrations of the eye, which means cornea, lens, all the way through. We can evaluate corneal aberrations separately, as you see over there, based on topography, and we can tell which aberrations are attributed to corneal irregularities. And if we subtract, we take the corneal aberrations out of the total aberrations, we come up with internal aberrations over there. And these internal aberrations will be attributed to the lens, either the crystalline lens, if it's a phakic patient, or the intraocular lens, if it's a pseudophakic patient. So we can measure internal aberrations, and we see how high they are also in monofocal lenses or multifocal, diffractive, EDOF, whatever. So we have an objective way of evaluating these lenses. And what we've seen over there is that part of these internal aberrations are high-order aberrations, and there's a specific high-order aberration that is the internal spherical aberration. And EDOF lenses work by increasing these internal spherical aberrations, but in a way that the MTF which is the equivalent, let's put it like this, to the contrast sensitivity, does not drop below 30%. So if we have this line being outside that box, let's put it simply, then this means that the quality of vision and contrast sensitivity in our everyday life and requirements, in our common and usual requirements, is acceptable, is not affected. So we do need this slight increase in the negative internal aberrations in order to achieve the depth of focus, but we don't want to decrease contrast sensitivity and have an MTF below 30%. If we have that, like we have with LUCIDIS, and this comes out of a study that we have performed after implanting LUCIDIS lenses, and we've shown these results in Copenhagen a month ago, then we have the optimal quality of vision post-operatively. And you see that we have a ray tracing refraction of 0 after implanting a lens. We don't have that negative false, let's say, reading that you see usually after a multifocal diffractive lens. So if you measure a multifocal diffractive lens, it looks like being myopic. We have a ray tracing objective evaluation that is 0. You can see these internal negative minor spherical aberrations. And we compared this, because that was a study with monofocal lens in the one eye and LUCIDIS in the other eye, because we need to keep in mind that even monofocal lenses induce a bit of aberrations. And we've measured the high order internal aberrations, and we see that with regard to coma and trefoil, there was no difference, no statistically significant difference between the two groups. There definitely was a difference regarding internal spherical aberrations. Otherwise, EDOF technology would not work. But then when it comes to the MTF, the internal modulation transfer function, which corresponds to the quality of vision and the contrast sensitivity, this line over there of LUCIDIS did not drop below 30% and did not enter that box, which means that it did not affect the quality of vision in everyday practice. And as I said before, pupil size does matter when it comes to diffractive lenses and when it comes to other EDOF lenses. When it comes to LUCIDIS, LUCIDIS works even with small pupils. Even with 2 millimeters pupil, even smaller, LUCIDIS works. It's the only EDOF lens, it's the only lens that will work even with a small pupil. And of course, you avoid dysphotopsia, as Alexander said, which is actually rings. There are no rings, no worries, no rings, no dysphotopsia. Let's compare now a non-diffractive, a LUCIDIS, with a diffractive lens in the same patient. That's the same patient, implanted in the right eye with a non-diffractive, in the left eye with a diffractive. Actually, that was a nurse in my hospital. Not the best quality of cornea, not the best quality of mindset, but that's a different story. Anyway, she was asking for multifocal lens correction. So we corrected her myopia, her astigmatism, everything with a diffractive. We went for a diffractive lens because that's what she was asking for. I said, okay, EDOF is the best choice. No, I want to be able to see at a close distance because I'm working in the hospital and I need to read all the papers, etc., etc., etc. But I said, EDOF, LUCIDIS will work even better. No, I want a diffractive. Okay, she got a diffractive and look at the quality of vision. It's really good. Well, she's happy, but she could not drive at night. I had informed her in advance, but you know, the patients have the tendency to remember what they like. And then they come back complaining. And when you tell them, well, I told you, yes, but you didn't stress it enough. But I wrote it down. I gave you a leaflet. I didn't read it. I don't remember where it is. Well, then it's always our mistake. Well, it's not our mistake, but You admit that, and then you go for a LUCIDIS in the other eye. And now she's happy. But she can still tell the difference. She's happy. So that's a nice example of mix and match that you can do. So if a patient is not happy with his diffractive multifocal lens, don't rush to take it out and exchange it for a LUCIDIS. Well, it's good for LUCIDIS though, but it's bad for your coronary arteries. So implant a LUCIDIS in the other eye. Just allow for 1 to 2 months for neuroadaptation, because neuroadaptation with LUCIDIS is much faster than what we were used to regarding multifocal, previous older types of multifocal lenses. And in the majority of the cases, the patient will be happy in the end. However, he will always be able to tell the difference between the two. So he will be happy with both of them. He will be able to read even with each eye separately, because LUCIDIS is more than sufficient for reading, definitely. Alexander showed us the results. We see that in our everyday clinical practice, but they can tell the difference in the quality of vision. And you know how they describe it? With a diffractive lens, the first complaint is the rings around the lights, which shouldn't be bothering them, but it's still there. It's like the patient's complaining about floaters and saying, well, yeah, I have floaters everywhere. Yeah, but this does not decrease your vision. Yes, but it's annoying. Yeah, okay, we don't need to do anything about it. Please, doctor, take the floaters out. And you perform a floaterectomy with no reason. But there is a reason, because the patient is annoyed. Okay, so there is a reason. So rings may not decrease visual acuity, but they are annoying. On the other side is the non-diffractive in the same patient. So more continuous quality of vision throughout all distances, but they might describe it like dimming the light a bit. It's like you have a dimmer and it's a little bit slightly lower. That's why you suggest that they use a bit of more light. We were doing that with multifocal lenses because we wanted the pupil to constrict a bit and take advantage of the central area that was meant for reading. And we were asking for brighter light for that reason. But the reason that we ask for more light regarding EDOF lenses in general, and maybe also for LUCIDIS, not that much for LUCIDIS, but also for EDOF lenses in general, is that we need more energy to enter the eye, because this whole energy is distributed over a longer focal distance. Our crystalline lens is using 100% of the energy of light that enters our eye to focus it on a specific point. So it changes the focal point, 100% focusing at this focal point regarding far vision, or at a different focal point through accommodation. Again, the whole of the light goes there. In theory, it's not the whole of the light, it's 90%, but it goes there where the brain decides. When it comes to an artificial lens, a bionic lens, it does the same job, but then it gives all the light, it attributes it over a longer area. So you need more energy, more photons to go in the eye in order to achieve the same outcome. Again, you see the non-diffractive effect. And this is the right eye and the left eye of the same patient. It's what I described before. Refraction is the same, high order aberrations are the same, but there are no rings in the non-diffractive EDOF lens. And using ray tracing technology, we can also obtain a depth of focus. So this is a distribution in the depth of focus that you see over there, that the non-diffractive, namely LUCIDIS, was a bit wider compared to the diffractive. We would expect that the diffractive lens would give more a wider depth of focus. On the contrary, the non-diffractive one, LUCIDIS, gave a longer depth of focus compared to the diffractive lens that had been implanted in the other eye of the same patient. So we got rid of rings, and it's useful and performs really well also in small pupils. And again, don't forget about aspheric monofocal lenses also inducing some kind of aberrations, as we can see there. So this is a comparison of non-diffractive EDOF with an aspheric monofocal. Similar dysphotopic phenomena like an aspheric monofocal. So it behaves like a monofocal lens, but at the same time performs like a multifocal, as you see there, because it can also give intermediate and near vision. And of course, they bother less compared to diffractive, which is confirmed also with by the literature. And this is again a comparison of non-diffractive versus diffractive versus aspheric. And you see that the non-diffractive lenses bother much less than diffractive and similar to an aspheric monofocal lens. So we are talking about no rings, which means no dysphotopsia, minor photic phenomena, especially at night. No one with LUCIDIS will complain about problems at night. So the only concern, the major concern that we had previously with diffractive lenses, that, oh, how are they going to behave at night? And the patient will come back complaining about difficulty driving at night. We don't have that when it comes to LUCIDIS. We may have the only concern regarding light. They need a bit more brighter conditions. So you tell them in advance to have that in their mind. So no significant difficulty at night, and none of them had to be removed. I have implanted hundreds of them. I didn't have to explant anyone. And that's thanks to the continuous vision that we can see over there. But there's no freelance, as I told you, because in order to have that, you need just a bit of more lights. We've seen cases with small pupils, and now let's move to another tip that has to do with centration. When it comes to premium lenses, every step of the surgery may make a difference. And of course, we go for a perfect surgery, but it's never perfect. We know that. When it comes to capsulorhexis, it's better to perform a smaller capsulorhexis than what we are doing usually. So if you perform a 5.5, let's say, millimeter capsulorhexis, go for a 5 or even smaller. It won't be more difficult for a surgeon, for any surgeon, and unless it's a really hard rock cataract, but it's good because if you need to align the lens in a decentered position, because you know you need to adjust to the visual axis, then this will be feasible and easier to be done with a smaller capsulorhexis. So go for a smaller capsulorhexis because in this way you can decenter the lens in order to align the lens on the visual axis easier, and the lens will stay there. So you see that in theory, we tend to center the lens and be concentric with the pupil, concentric with the capsulorhexis, and then the central element of the LUCIDIS lens to be concentric to the other two circles that we have there. However, when angle alpha, not angle kappa, when angle alpha is wider than expected, something that is commonly happening, for example, in hyperopic patients, for the same reason that they have a big angle kappa, they may also have a bigger angle alpha. Then we will have to decenter the lens, usually on the horizontal axis. That's why we align the lens with the haptics vertically in a way that we can decenter it slightly horizontally and align the lens on the visual axis. We can use it either using intraoperative technology, image guidance, like the Verion or whatever you are using, and choosing instead of alignment on the limbus-based alignment, to choose the visual axis alignment. That's the one way to do that. But there's also an easier way to do that, since most of us are performing surgery under topical anesthesia, under drops. Then you just ask the patient to look at the lump and you evaluate the Purkinje images, the reflection. And you need to put this reflection, you have a reflection or two reflections. Usually we have double or three lumps in the microscope. So you see three lumps over there, or two lumps, two reflections. And it's one level comes from the lens and another level comes from the cornea. If the two are aligned, then you have a perfect alignment. But even if you cannot do that, at least you want the brighter Purkinje reflections to be centered on the central aspheric element of LUCIDIS. So you ask the patient to look at the lump, given and provided that he's cooperative and he can listen to you and he can cooperate. And then you move the lens so as to align it on this Purkinje reflection. Since LUCIDIS lens is hydrophilic, which means that it's softer, this will help you do that maneuver. And it may take time, so just be patient and allow for some time. That might be even 1 minute or 2 minutes. It may look long, but it's required because it will save your life. So just allow for that minute of alignment and proper centration of the lens. You release any back pressure that you have. You perform anterior and posterior capsule polishing. I will show you pictures. You remove the viscoelastic from the back of the lens, and you allow for some time for the lens to settle. Rotate it all around. It's soft. You can do that. It's easier to manipulate a hydrophilic lens compared to a hydrophobic, and easier to decide about the alignment of a hydrophilic lens. So LUCIDIS has a privilege in that aspect. And as I told you before, that's how you align it, based on the Purkinje reflection or taking advantage image guidance intraoperatively. Another issue is to choose the right size. There is no rule of thumb and there is no definite and precise, let's say, classification. What I'm doing is my standard size is the 108 because I can align it easier and decenter it. However, since it's smaller in size, it may rotate and decenter by itself also easier. But in theory, in short eyes, as Alexander showed you before, short means below 20 millimeters. These are very short, but also below 22. You definitely go for an 108. If it's longer eyes over 26, then you definitely go for 124. Regarding the in-between, which is the majority, both sizes will work. I prefer the 108. When it comes to toric, maybe the 124 is more stable regarding rotation, but I will show you an example that rotated. Even the 125 may rotate if you have a huge back. So nothing is perfect, but choose what is more adequate for you. And you see the centration over there. Well, this doesn't look that centered. However, LUCIDIS is forgiving, also if it's slightly decentered. So that is the central element of centration. It's within the pupillary area. So even if it's slightly decentered, that is 0.5 millimeter, the lens is working and functioning perfectly, no problem. So a slight decentration is definitely forgiving, provided the central element is within the pupillary area. Apart from posterior polishing, also perform meticulous anterior capsule polishing. JAG laser will be required in very, very, very few cases. This is a general observation regarding hydrophilic lenses. It has changed over time. What we were saying in the past is not true nowadays. It does not, hydrophilic lenses do not require more YAG laser to be performed more frequently than hydrophobic. The difference is very slight, provided that we have performed posterior and anterior capsule policing. So don't rush to perform YAG laser. It may be more frequent in younger patients, and you will have younger patients there because it's a refractive procedure, as I said. So you may be having more and more 50 or 55-year-old patients undergoing refractive lens exchange and being implanted with the LUCIDIS. So you expect posterior capsule opacification at a higher rate in these ages. However, it's not as high as you thought or as I expected. In our clinic, it's less than 5%. And again, sometimes you see some starting PCO and you rush to YAG it, YAG laser it, although that might be not the reason of poor functionality, of poor function of the lens. It might, usually it's the tear film and not PCO. And we overlook the tear film, focusing on the PCO that we expect to see. Some cells at the posterior capsule do not necessarily have a high impact on the quality of vision. So the incidence of PCO is much lower than we expected. It's much lower in modern hydrophilic lenses compared to older hydrophilic lenses. And don't rush to YAG laser a patient, because that might not be the reason of poor functionality of his vision, and it's not the lens, and usually it's the tear film and the cornea. And look, these are intraoperative pictures, and look how nice it looks after polishing the anterior capsule and then implanting a toric lens, for example, in that case. It's not only that it looks better, but it also functions better. What about that case? This is anterior segment OCT. That is the lens. That is the posterior capsule. Look at this area over there. And why is that? That is the lens. What is in there? It's viscoelastic that I did not remove. So it was my mistake. And it's funny because that patient did not present with a significant hyperopic, myopic shift as I expected in the first place. Actually, he was very happy because his reading was very nice. However, in the course of time, that became more opaque, was opacified, and then it's then that I realized that I had left viscoelastic. Why did I do that? Because I skipped it. Because the pupil was small, because I had a difficult time in the operating theater, because I was scared to go behind the lens, because I didn't have space, because I didn't have time. It was my mistake. Since it's a soft lens, it may be destroyed if you're not careful when implanting the lens. So be careful with regards to the injector that you are doing, that you are using. And you can use it in any challenging cases. I will describe only one case for the sake of time, because that's the patient that will come to you and ask for a multifocal lens. It's a presbyope, former hyperop, who has undergone hyperopic LASIK. It's the same patient that you operated 20 years ago or 15 years ago for hyperopic LASIK because he didn't want to wear glasses. The same patient developed presbyopia, and now he does not want to wear glasses again. So this is a challenging case because this is your target regarding far and near and intermediate. That's what you want. But that's a strange case over there because at the beginning you consider that being a hyperopic shift, a regression of hyperopia. Well, that's what you expect. It's just a 50-year-old guy sitting in front of you. And then you realize that internal aberrations are like that. So it was probably a dysfunctional lens syndrome. And after exchanging the lens with LUCIDIS, he's happy. You can see that central area of aspheric, of that central negative spherical aberrations that give the depth of focus, and you see the refraction being 20/20 and J1 from day one after surgery. And again, another case, and you see how it works, and you see the refraction that we have. And over there, you see the spherical aberrations, minor induced by the EDOF lens in the center, that disc over there, and that ring is due to the previous hyperopic LASIK that he had. Toric lenses also for hyperopic astigmatism. This is another extreme case. Look at the power of the lens that we had to implant. We had the tendency to overcorrect these short eyes. That's not necessary to do now, because with Barrett formula, Barrett Universal 2 works much better, and you can target for zero, target for emetropia. Don't need to overcorrect. Barrett performs much better compared to previous formulas. And you can see the corneal astigmatism over there, the internal astigmatism induced by the lens because it's a toric lens, and then you come up with neutral astigmatism in the end. Minor rotation, although it's 1.8, the small size of the lens. Reduced high order aberrations that you see over there. That's the evaluation of the dysfunctional lens syndrome, and that's how the extended depth of focus works, and the central power induced by these lenses. Let's move to extreme lengths now. This is another case with which is longer than 30 millimeters. This is the lens that we implanted, toric, in both eyes. That's the corneal astigmatism. That's the internal. Well, something's wrong over here. Something's wrong because in the end, he still has a lot of astigmatism at a different axis. What did I do wrong? Well, probably I did something wrong because the lens rotated. And that was a 124 multifocal EDOF. It was a LUCIDIS 124. That was the big size. But that was a really tall patient, really long eye, really huge bag. So even the bigger size may rotate. Maybe he was rubbing his eyes. I don't know. But it did rotate. Of course, I had to recenter, realign the lens, but it may happen. Although in general, we had very, very few rotations. It's less than 5% of the toric implantations that need to be recentered. And this is what you come up with, the calculator that Alexander showed you. These are the lenses. This is how to calculate that. And this is the outcome of the other eye that we were more meticulous. It took us a little bit longer. We instructed the patient accordingly what to do with the other eye. And again, you see that it performed much better, but still a bit of astigmatism remaining over there. And we can evaluate the depth of focus. And this is another series that we also presented in Copenhagen, refractive lens exchange in eyes with high myopia, long axial length. We're talking about an average axial length of 28.5. You see the range of diopters that we implanted when we are talking about young patients over their mean age of 48. With presbyopia, of course, we chose the 124 for the exact reasons that I explained before. We use ray tracing aberrometry. We use Barrett formula, Barrett Universal 2. This is the pre-op refraction. This is the dysfunctional lens syndrome confirmed with the dysfunctional lens index. This is the MTF measurement, and this is the post-operative evaluation with almost zero refraction over there. A little bit of internal spherical aberrations to achieve the depth of focus. MTF over 30% in all of the cases. Angle alpha does make a difference. This is what I said before. Although with long eyes, high myopia, you don't have such issues. You do have that with hyperopic eyes. And you see that that's angle kappa, that's angle alpha. They do not, these circles are not concentric. And this will make the difference in the angle. And again, in the other eye. So with LUCIDIS, you can decenter the lens in a way that you align it as you want. However, near vision is not sufficient in long axial lengths. It's not sufficient because the depth of focus does not cover the requirement of a long axial length. That's why in such cases you go for a mini monovision or even a modest monovision. You can wait for 3 to 4 weeks, then perform, after operating on the first eye, then perform subjective refraction, evaluate and decide for the offset that you want for the other eye. So if you need an additional correction of, let's say, 1 diopter for reading in the first eye, then you offset the target of refraction in the other eye by 1 diopter, and you have the full length. You have what you want. That's what we did over here, for example, this modest monovision, and this is how we extend the depth of focus targeting. This is the offset of each eye, and that's how we elongate the depth of focus, because this is what is required in longer eyes. Mix and match, monofocal, non-diffractive EDOF. Let's say that it's a patient entering your room, already implanted with a monofocal in the one eye. He heard about multifocal lenses. He's asking you to explant the monofocal lens and put a multifocal in there. Don't do that. Implant a LUCIDIS in the other eye, targeting for his requirements, what he wants most. And if he's not happy, then you exchange the monofocal lens. Most of the patients will be happy with monofocal in the one eye that had been already implanted and LUCIDIS in the other eye, because even after implanting LUCIDIS in the one eye, they have sufficient near vision. And that's why we can implant it even in monoculus patients. You can see the difference between the monofocal and LUCIDIS. It's a lower curve because of the amount of light that needs to be distributed over a longer area. And again, this is how it works with a monofocal in the one eye and LUCIDIS in the other eye. And as I told you, since near vision is sufficient already after having implanted the first lens in the first eye, we dare to implant it also in monoculus patients like this one with good results. Mini monovision means an offset of about 0.75. Modest monovision is an offset of about 1.25, 1.5. But either way, we adjust it. When we perform mix and match, we adjust it to the requirements of the patient. And again, this is a mix and match with a monofocal and a LUCIDIS, similar aberrations, but sufficient near vision even after implanting LUCIDIS in the one eye. And you can see that the comparison between the monofocal in blue and LUCIDIS in red, you see how wider the range of focus is over there. Again, another case with hyperopic LASIK, but I want to move to something more challenging. After myopic LASIK, it also works very well. Just wait before you operate on the other eye. Don't rush. It takes, in theory, about 3 to 4 weeks for the lens to settle in the bag. Don't forget that you explant a crystalline lens that might be up to 5 millimeters thick. It's thick not only in older patients with a progressed cataract, it may be thick also in young guys over there with hyperopia. So you explant a thick crystalline lens that could be up to 5 millimeters and implant an artificial lens that is almost half a millimeter. So it's 10 times thinner. This needs time to sit in the final position in the bag. Please allow for some time for the bag to shrink and lock the lens in place. It happens within 3 to 4 weeks. Well, in this patient, it took even longer. And you see the variation, you see how refraction changed over time. Well, I don't ask you to wait for that period, but 3 to 4 weeks is usually more than enough. And then you decide about what to do with the other eye. And you can subjectively, That's the only case that you use subjective evaluation, subjectively evaluate the performance of the lens and decide about the other eye. Can we use that in subclinical keratoconus? Why not? That's what I'm saying. So if we have a minor keratoconus, not progressed, we know that it may not perform that well, but why not? Since high-order aberrations, additional high-order aberrations induced by the lens are minor. So why not use it? And we accidentally realized that a small decentration of the lens may counterbalance coma, because this small decentration induced coma that was reversed to the corneal coma, and we ended up with zero coma. Well, that's not always the case, of course. That's an extreme example. It just happened by accident. I was not intended to do that, but that's how we observed it. And this is, again, EDOF in subclinical keratoconus, non-diffractive. The problem is which axis to choose. There is one axis over there, astigmatism, and there is another axis, which is coma. So where is the catch over there? Should we go for correcting corneal astigmatism, or should we go for correcting coma? And this axis, these different axes do not match in most of the cases. Well, that is a problem. I don't have an answer to that. So if you are confused, what I'm doing is implanting a non-toric LUCIDIS. So it's a non-toric, I go for a non-toric LUCIDIS and try maybe perform a topo-guided PRK afterwards to adjust and reduce corneal aberrations. But overall, why not also in subclinical or minor keratoconus? So going back to the take-home message where we started with, use the term visual quality, dysfunctional lens syndrome, which can be measured with dysfunctional lens index, refractive lens exchange instead of clear lens extraction, non-diffractive EDOF, refractive lens. LUCIDIS gives a full range with non-diffractive technology, behaves like a monofocal. These are the pearls, how to use it and how to perform best. So I use the term EDOF varifocal plus. So skip the term multifocal, use varifocal, use the term plus because it gives more than sufficient reading capability, behaves like a monofocal, performs like a multifocal. Do not hesitate to use it.